Welcome to the Ty Beal Show, where we discuss food, science, and life. I'm Ty Beal, a scientist at the Global Alliance for Improved Nutrition, or GAIN. My guest today is Dr. Ethan Weiss, a renowned cardiologist, professor, and chief scientific officer for Marea Therapeutics, which leverages the latest advances in human genetic data to develop next-generation therapies for cardio-endocrine diseases. Dr. Weiss' special interests include preventive cardiology, genetics of coronary disease, risk assessment, and heart disease in the young. In our conversation, we discuss cardio-endocrine diseases and what that means, prevention, genetics, low-carb diets, and time-restricted eating. A quick note before we start. This podcast is separate from my role at GAIN. Okay, let's jump in. Dr. Ethan Weiss, welcome to the show.
Thank you. Thanks for having me.
It's really great to talk with you. I've followed your work for several years now, so it's nice to be face-to-face, even if remote.
Yeah, actually, I never did ask you this, but where are you located?
I'm in Phoenix, Arizona.
Not too far.
We're in the same time zone right now. It's pretty rare that I get to talk to someone in my same time zone.
Does it change when we go back to standard time?
It does. Yeah. Phoenix doesn't have daylight savings.
Right.
So, yeah.
As it probably should be the rest of the world, but
that's right.
Yeah.
All right. So I'm really happy to have you on. We're going to learn a lot. And can you just maybe to start us off here, can you share a little bit about what got you interested in medicine in general, but then specifically into cardiology, and what led you to focus on preventive cardiology and genetics?
Yeah. Well, I'll try to be succinct because these can turn into long stories, but I did grow up in the home of a cardiologist. So my dad he's retired now, but he was a cardiologist in academics for a long time, 50 years. And so I grew up around it. I grew up, having summer jobs in the hospital. And actually, one of my very first jobs when I was in middle school was to go and sort microfilms that's how they used to store patient EKGs. And they were literally on like a card, and then there was a little microfilm. Anyway, it was, I grew up in and around the hospital. I didn't really have an aptitude for science in high school. And so I didn't think that medicine was going to be a career for me when I went off to college, and kind of intended to do something completely different. I think both because the things I was thinking about doing were sort of unrealistic, at least if you wanted to actually, make a living. And also
because driving.
Well, no, I was really into music. I wasn't ever really talented enough to be a musician, but I thought I'd be involved in music in some way. And anyway, it was.
So what did you play? What did you do? Because I did music too.
So the very first instrument I played when I was a young kid, was the violin, and and both my parents are and were very musical, and they met in music. They actually met in music school in the late 1950s.
Wow.
So music was a big part of our house. So they had me start playing the violin when I was 2 or 2 and a half, old enough just to hold it.
You came out of the womb and you were handed your first bow.
Yeah. But I made a deal with my parents. I think I was probably in 4th or 5th grade, and I said, "Look, I don't want to give up music, but can I switch instruments?" And they said, "Sure." So I ended up starting to play the trumpet at that point. I played the trumpet from that point all the way through until I graduated from college. And it's one of those instruments you can't really just like pick it up. So once I started medical school, that was the end of my music career. So
yeah, you transitioned to the next thing, huh?
Yeah.
Well, I played drums and I did some music production. So I did mixing in LA for a little bit before my my current field here.
Well, there you go. That was sort of what I had in mind. I knew I loved music and wanted to be involved in some way, but I wasn't sure what. But in any case, I did take a few science classes in college, and I don't know why, but things just were better. I enjoyed it more. It's probably the two that were linked. I enjoyed it more and I was better at it. And then of course you start to think like, what am I going to do with my life? And so I sort of started to think maybe I'll go to medical school. So I took the sort of bare minimum requirements for medical school at that time. It was really truly bare minimum, and non-science major, and sort of really kind of did it just because it was a reflex and it was what I knew, and I applied and I got in. And so I went off to medical school. But I went off to medical school at a time when science was sort of exploding, and I just didn't have any idea about it. I mean, um, it was really overwhelming for me in
like
a
a
lot of different
fire
ways.
hose of
Yeah,
information.
and it was also a time, I think, in at least, at this medical school where I went, it was a time when the curriculum was so heavily weighted towards science, like really hard science, that I would say,
Yeah.
I mean, I don't know if the exact numbers, but I would say a full 90% of our classmates were science majors, and probably of those, only half are biology majors, right? The biology majors weren't even considered science majors by the really hard science majors. The hard science people were like biophysics and biochemistry and chemistry and
Yeah.
physics. So I kind of self-assorted with the group of non-science majors. There were only, a handful of us, and we struggled through a really hard first year together.
I
And
can imagine.
I mean, it was definitely not an enjoyable. It was not enjoyable. I mean, it was enjoyable in the way you like. I guess if you had to, like, grind through getting through like a marathon or something, but
Yeah.
it was definitely not. It was there. I did not have. It didn't come easy. So anyway, I'll just like basically fast forward through the next however many years. I ended up kind of falling in love with science. I went and worked in a lab on the advice of some people who were mentors to me, and they said, do that because it'll slow down the concepts. It'll make it easier for you to understand. I ended up loving the lab. And so when it came time to kind of think about my life, I happened to work at a lab that was focused on cardiology. And so I kind of went backwards. I sort of, even though my dad was and is a cardiologist, I didn't come at it from the standpoint of, I've always wanted to be a cardiologist. I didn't. In fact, when I went to medical school, I really thought I was going to do something completely different, like public health or psychiatry or something that was like not related to any of this
Hmm.
stuff. But this, because my scientific interest was so closely related to cardiology and to cardiovascular medicine, I kind of decided that that's how I should, sort of direct myself clinically. And so that was how I ended up doing that. And
Okay. So,
yeah.
so what about, did you have any sort of aha moment or some unexpected result that pushed you toward thinking about this cardio-endocrine mechanisms? Because that term, maybe you can define it, but some of your work has been sort of around this combination of cardio-endocrine mechanisms, right?
Yeah, I mean, I'm not trying to claim that we did anything like super creative, and maybe somebody else has been using the term forever, but we just made that up. And partly because there's a world where people are now familiar with cardiometabolic, and because we
Mhm.
have these two programs, we certainly do have one program that's squarely cardiometabolic, meaning it's, sort of got a cardiovascular angle. We're developing it as a drug to help reduce the risk of atherosclerotic coronary artery disease, but it also has an effect on lipids, which is clearly sort of within the metabolic world.
Mhm.
Our second program is a rare neuroendocrine disease that's really completely not cardiac. I mean, there are cardiac issues related to it, but it's definitely not metabolic, at least not primarily. So we sort of decided we'd think from a kind of higher level, we'd marry cardiology and endocrinology, and then as you drill down a little bit, you can get to the different subspecialties. So in the endocrine world, we're sort of squarely in metabolic and neuroendocrine. So that was sort of how we came up with this idea of calling it cardio-endocrine. The way I got into metabolism was completely by accident, and was a product of, I think, what's great about science, which is that you do experiments and they take you to places you don't expect to go. And so we did an experiment, a mouse genetics experiment now 20 something years ago, and got a result that was fascinating and exciting, and it was more exciting than what I was working on. And it was clear to me and everybody else in my small lab at that time that that was the case. And so slowly over a few years, we kind of pivoted away from what we had been doing and really focused on these metabolic things. And, over the course of my career in academics, which was, 20 plus years, I really spent the majority of my time focused on metabolism. Now, back then, there wasn't really this marriage of cardio and metabolic, or cardio and endocrine. I had to do a lot to convince people that this made sense. Since then, now, of course, there's a huge connection. And so if you go to any of the national meetings, heart meetings, like American Heart Association, American College of Cardiology, ESC, you'll find a huge section of endocrinologists there, because there's a lot of interest in diabetes and lipids and all these other things. And same thing in the endocrine meeting. So if you go to Endo, or if you go to American Diabetes Association, you'll find there's a huge amount of cardiology there too. So there's definitely now a world where the two Venn diagram circles have come together. I wouldn't say they've merged, but there's definitely a lot of overlap. So that
Okay.
one makes sense.
So it's moving. So this field is sort of moving to a bit more holistic, not treating heart disease or metabolic diseases separately, but kind of considering them together. Is there are there sort of trade-offs sometimes when you think about either therapies or lifestyles that benefit one or the other? Is that part of the reason to look at them together, or what's the benefit
Well,
of
I
that?
mean, I think the main reason to look at them together is that if you think about, let's just say take diabetes, which is sort of the sort of quintessential metabolic disease.
Right.
People, and I'm sure the endocrinologists will kind of hate me for saying this, but people generally don't die of diabetes. They die of complications from diabetes. And the most common of those complications, most common reason people die in the world, period, is still coronary artery disease, heart disease. And
Right.
so in diabetes, again, the most significant risk, if you take away some of the end organ stuff and the microvascular things that happen in the eye or the kidney and other places, it's the heart and so heart attacks. And so I think, both specialists now recognize that that's so important. So we as cardiologists recognize that, one of the biggest risk factors for developing this disease that's still the number one killer of people in the world is metabolic disease, or specifically diabetes. And I think that diabetologists and people in the diabetes and endocrine community now realize that, yes, of course, the metabolic stuff is super important, but at the end of the day, what happens, when people get into serious trouble is that they have heart attacks and they die. So
Right.
that's, I
So
think,
yeah, it's the number one cause of death in the U.S. And is that worldwide too?
Yeah, I believe it is. I mean, there was a period of time with COVID where that changed, but I'm pretty sure it's still number
Yeah.
one worldwide. And then partly that's also because, well, the incidence of disease here, particularly severe and fatal disease, has gone down a lot because of the availability of all these amazing treatments. We sort of exported a lot of the things that maybe tend to kind of promote these diseases to the rest of the world. So, you walk around the Far East and you see lots of evidence of the West. You see McDonald's and cigarettes and all the things that sort of plagued us in the 50s, 60s, 70s.
Yeah, I remember driving, this is maybe a year or two ago, driving around in Mozambique for some work that I was doing. And I could see, even in rural areas, just Coca-Cola like everywhere on every, even their little homes and the walls. And I was like, I asked someone, I was like, why is that there? And they're like, well, they offer to pay to paint their house or
Yeah.
their wall if they get the logo right. And so, yeah, they have really, the food industry has really infiltrated all areas of the globe, just about.
Well,
But
food and tobacco as well. I mean,
yeah.
as tobacco restrictions and regulations have gotten to be more severe here, and the number of people smoking cigarettes here has obviously gone way down, I think the world has more than picked up the slack.
There's a lag. There's oftentimes it comes from here and then it
Yeah.
shifts somewhere and
Yeah.
then it changes here, but it takes a while to catch up
Yeah.
elsewhere. Okay, so let's talk about cardiology specifically, because it's the leading cause of death, super important. And you are a cardiologist and
Yep.
you've done specific work in preventative cardiology. So can you tell us, maybe starting with, what are some of the most promising advances in risk assessment today? So thinking of things like genetics or novel biomarkers or imaging, things like that.
Yeah, the basic form of how we assess risk in patients remains very similar to the way it was initially sort of developed and described at Framingham in the 1950s. I think the vast majority of risk can be attributed to things that everyone's familiar with. So still far and away, probably the biggest driver of risk is the biggest one is, have you had an event in the past? So have you had a heart attack in the past?
History,
Set that aside and think about primary prevention. Do you smoke cigarettes? And then go down the list, right? And I'm not going in order, but we all know the rest. Is your blood pressure elevated? Do you have hypertension? Do you have diabetes? Do you have high cholesterol? I mean, I think those are the sort of the core of how we think about risk. The specifics of how we measure and quantify that risk has changed a little bit over time. And then there are adjunct things that we do to help understand risk of future events, specifically things like imaging. Obviously, we've talked about biomarkers, and then, in terms of genetics, that we're still sort of early days, believe it or not, on the use of genetics, at least as a clinical tool to help predict risk.
Is it more research focused?
Yeah, I mean, we can do a decent job on a population level of sort of saying, at least retrospectively, okay, well, if somebody has this genetic makeup or this group of genes, does this cause an increase in risk of them developing a heart attack and dying from a heart attack. Yeah, we can do that. On an individual basis, it's really still quite hard to be able to say, do a gene analysis of your genome and to say anything meaningful about what your risk is going to be based on the genetics alone. So we're getting to a point where it's people are starting to sniff around, but it's still early days. I think in the past 10 years, the biggest change, at least in my practice, is the advent of imaging, and specifically in looking for evidence of plaque. And there are lots of different ways to do that, but I think that's the biggest change. Whereas maybe when I first started in practice in the early 2000s, we're really just focused on biomarkers and history. Did your mom and dad have a heart attack? Did you have a heart attack? All that stuff. Did you smoke cigarettes? And then also, what are the, what's the blood pressure? What's your cholesterol? What are the different subfractions of your cholesterol? So I think the biggest change now is the advent of kind of standard use of imaging to help supplement the information we get from everything else.
Okay, so let's talk about these. And obviously, you can't control whether you've had an event, but there are things like smoking that you can control. So that's a pretty obvious one. How about these other markers? So let's think about, maybe give us some tips on lifestyle or clinical interventions if necessary for blood pressure, for maybe diabetes risk. So maybe you have pre-diabetes or something, or high blood sugar, cholesterol. Tell us about what can we do, like in general, what are some of the main things that we can do to address these?
Yeah, so each of the three things you just mentioned, so blood pressure, cholesterol, and diabetes, they're all things that can be addressed with lifestyle, and they all have an abundance of evidence to suggest that there are different lifestyle interventions you can make to help reduce the risk of, in whatever it is, reduce the risk of developing diabetes, reduce your A1C, reduce your blood pressure, reduce your cholesterol. So I think sometimes those line up where you might see the same intervention would do for all three. Sometimes they don't. A lot of times it's not even necessarily, there's no one answer. There are probably lots of different answers. So we can go through all three. I mean, I think, the most common things, if you just start with blood pressure, the most common thing that you'll hear people talk about is salt. I think intake of dietary salt probably matters. There's a debate, and when you get into the weeds and really into the nuance, there is some question about how much it matters in an individual and versus not. But I think that evidence base has been around for a long time, and I think it looks to be real to me. The other things,
of course, how much potassium kind of matters too.
That's right.
Yeah, some other nuances.
So then the other things that tend to matter on a lifestyle basis for blood pressure, weight is obviously super important. We know that if you lose some magnitude of weight, you reduce your blood pressure almost in a linear fashion. Alcohol is another one. I don't remember the exact numbers. I used to lecture the first year medical students on blood pressure, and I can tell you exactly sort of what how many ounces of alcohol would lead to what number of millimeters of mercury change in blood pressure. I don't know those numbers anymore, but it certainly is a contributor. I don't know if this falls into lifestyle, but certainly, certain things like oral contraceptive pills can increase your blood pressure. There are a whole host of other things. Oddly enough, licorice can increase your blood pressure in certain people.
I haven't heard that one.
Yeah, it's like a funny one. When you see somebody who has new onset hypertension, they come into the office and it's like come out of nowhere. One of the first questions that I ask is, have you started eating a lot of licorice? And I'd say in the probably 1,000 times I've asked that question, I've gotten a yes answer like twice. But it's very satisfying when you do get that. So that's blood pressure. I think diabetes, we know from clinical trials and other interventions that there are things you can do to reduce your risk of developing diabetes and also reduce your hemoglobin A1C, either if you have diabetes or if you don't, or if you have pre-diabetes. I think the most kind of notable of those is weight. That's been shown however many different times. If you can lose a certain amount of weight, you'll
so whatever sort of helps you lose weight or stay within a healthy range.
That's right. It could be surgical, it could be medical, it could be lifestyle. It doesn't matter. Now, you will, within the different diet communities, you'll hear certain people say, well, it's really the vegan, diet that's the only way to do it. Or you'll hear people say keto or carnivore. I don't think it matters that much. Maybe, and I'm saying this as somebody who's myself been sort of, I wouldn't say strictly, but at least like mostly low carb for now almost 10 years. Maybe there's like a slight advantage to carbohydrate restriction, but the evidence is really not so strong. And I think the more important thing is that you lose weight. And so whatever you can do to lose weight probably makes a big difference there. So,
Okay.
the specifics about what you're putting into your body, the only other significant sort of diet that I think is worth mentioning, and it comes with some nuance as well as everything does, is Mediterranean diet. And that's because there have been a few trials, large trials, showing that people who adhere to what's called a Mediterranean diet have a reduced risk of developing new diabetes and also, importantly, coronary artery disease and coronary artery disease events. I think the issue there is that sometimes what's called the Mediterranean diet is really not the Mediterranean diet. It's sort of it's a diet, that's sort of generally kind of healthy, but then has the addition of things like olive oil or nuts, tree nuts, and things like
Right.
that. So,
Yeah, there's a lot of different types of Mediterranean diets,
yes,
I'm
of
sure.
course. Yeah.
So how about for cholesterol specifically?
Yeah. Cholesterol, I mean, the evidence basis is older and it's pretty clear. So if you really, really just want to lower your cholesterol through diet alone, then decreasing your intake of saturated fat seems to be the most important way to do that. There's a debate about overall fat, but I think in general, people feel like polyunsaturated fats probably not only don't raise cholesterol, but probably lower it as well. And there are some really good studies where they bring people into a ward and they do replacements, and they keep things eucaloric or isocaloric. So they're replacing calorie for calorie. They're keeping the total macro composition the same. So it doesn't help you if you swap out saturated fat for unsaturated fat, if you increase your protein intake, or if you do something, else to your carbohydrate intake or something like that. So I think, what you want to do is to do a controlled intervention where you really can isolate the one variable. And I think, it's generally agreed upon that if you just want to look at lowering cholesterol, particularly LDL cholesterol, then saturated fat is probably the most potent way to do that.
In terms of cutting it. So okay,
Yeah.
so let's talk about a little bit more specific biomarkers of ApoB, which is more of the atherogenic particles,
Yeah.
right? So does that sort of apply with the saturated fat in general when you're looking at ApoB as well? And
Yeah,
have you seen in your clinical practice, have you seen variation in that? Some people, they respond to it, some people they don't.
Yes. So to answer that question, yes, absolutely. I think most of it has to do with how easy is it to adhere to a specific lifestyle intervention.
Adherence.
That's
Okay.
and that, I think, probably more than anything else, is part of the reason why there's this tsunami of interest and excitement over medical therapies like GLP-1 receptor agonists for weight loss, not for cholesterol. But it is true that we human beings do have a hard time sticking to things, especially if they are not easy. The more complicated they get, the harder it is to stick to. We also like things that are pleasurable. Things that taste good are generally things that we like
Butter
to
tastes
have.
good.
Things are, it's a different world these
Yeah.
days. You have an option to eat almost anything you can get your hands on. You can DoorDash whatever meal you want to your house in 15 minutes. It's not like the old days where you had to go out and actually find your own food. And so I think, if somebody really wants to use diet or lifestyle just to lower their cholesterol, it's possible. It's not a huge effect, but it's definitely possible to make an impact, to make a dent. As for the specific biomarkers, so ApoB, you mentioned apolipoprotein B, it's the lipoprotein that is wrapped around these particles that carry these different lipids. And so there is an ApoB molecule on each of the following three things that we talk about relatively interchangeably. So one being LDL cholesterol, so one ApoB per LDL cholesterol particle. Two is LP little a, another particle that's sort of related to LDL cholesterol, important but different. And the third is a newer term that people are starting to pay a lot more attention to, which is remnant cholesterol, or triglyceride-rich lipoproteins. So all three have one ApoB. Now, there's a lot of work going on, and it's controversial work, and I think it gets a lot of attention. I think it should get a lot of attention. But there's a question out there about, on a per particle basis, so if you take one of these LDL particles, one of these remnant or triglyceride-rich lipoprotein particles, and one of these Lp(a) particles, how atherogenic is each? In other words, both in terms of experimental models, but also more importantly in big epidemiologic models, if you have more of one of them, does it promote more or less risk of coronary disease and events? And it's early days, but it doesn't look like it's one for one. It does look like where you sort of which kind of ApoB you have may change the amount of risk on a per particle basis. Now, the truth is, the most abundant ApoB containing lipoprotein particle that we have is LDL far and away. So
Okay.
if you were only to care about one thing and you were really thinking, I don't want to be distracted, I just want to care about one thing, then probably it's good enough just to care about LDL cholesterol, which is part of the reason why it's, we've had such success with paying attention to that biomarker in terms of kind of impacting the risk of disease over the past 25 years.
Okay. So what about, so we've talked about lifestyle. Now, what about more of the drug therapy, different types of interventions, maybe for, these different areas, but thinking of cholesterol specifically, what do you recommend? Is there sort of key things you start with?
Where we are today, I think standard of care is that if you have a reason to want to lower your cholesterol and you can't get where you need to get with lifestyle, which I think is the vast majority of people, not everyone, but the vast majority of people. And again, let's set aside the question of like, should you be lowering your cholesterol? Because I know that's a question that comes up all the time, but let's just pretend for a second that you and your doctor agree you want to. The standard of care is to start with a statin medication. And, look, there are hundreds of statins, brand name statins at least, but the vast majority of sort of modern cardiologists probably start with one of two. These are sort of they're not the latest generation because there are newer statins that are out there now, but these are sort of the third generation statins, the ones where there really is the most clinical trial evidence, not just of lowering cholesterol, but of lowering risk of a heart attack and importantly of dying from a heart attack. And so those two are atorvastatin, some kind of Lipitor, and the other one is rosuvastatin or Crestor. So in my practice, that's what I start with, is one of those two. And depending on how much I want to lower the cholesterol or how much I want to lower the risk, because sometimes I don't really care about the cholesterol, I care about the risk. So if somebody's had a heart attack, they come in and see me in the office and their LDL cholesterol is already 65. I don't care. I'm still putting them on a statin because that's still standard of care. And then
So it's the overall risk that you're caring about.
I mean, it's both.
Yeah.
Obviously, in people who've never had a heart attack, one of the biggest drivers of risk is what their LDL cholesterol is. But
what you can control, yeah.
So I will generally start a statin, again, depending on the risk, depending on the situation, depending on a lot of different other factors. I'll start one or the other at any of the doses, starting from the lowest dose up to the highest doses possible. And then beyond that, now, I mean, up until 20 years ago, there was really only one way to do this. There were lots of other old cholesterol medicines that no one uses anymore, including like niacin and gemfibrozol, other. But on or in or around the early 2000s, there was a drug that was developed to lower cholesterol called ezetimibe or Zetia, and that works through a different mechanism than statins do. So statins lower cholesterol. People think sometimes it's through synthesis because HMG-CoA reductase, which is the target of statins, that's important in synthesis of cholesterol. It turns out that's not really the mechanism of how you lower cholesterol. That you do so inside the hepatocyte, inside the liver cell. But what that does is it tells the liver cell that it's starved of cholesterol. So what it then does is upregulate the LDL receptor, a receptor that then sits on the surface of a liver cell, and that then scavenges LDL cholesterol and pulls it out. So basically what you're doing is you're upregulating the LDL receptor, which then pulls out LDL from the circulation. So that's the mechanism. Zetia works through a different mechanism where it increases clearance. And people again think, oh, well, it's taking cholesterol out of the diet. It's really not. It's mostly taking cholesterol out of bile that's secreted from your liver. So it's which is a huge source of cholesterol, and that usually then gets reabsorbed. So if you block this target of Zetia or ezetimibe called NPC1L1, you block that reabsorption pathway, and so you'll lower cholesterol modestly. So that drug was around for 20 years, and then starting around 2015, there was a new class of drugs that was came to the market called PCSK9 inhibitors, and those drugs work through a very similar mechanism to statins, and that's because that protein PCSK9, which I won't try and tell you what it is, that protein is important in regulating the LDL receptor, and so it degrades it. So if you block this protein PCSK9, what you do is you block the protein that degrades the LDL receptor. So what you're doing is effectively kind of keeping more LDL receptors up on the surface of the liver cell. So those are the kind of three main classes of drugs that get used. It turns out that there's a lot of work going on in drug development on the LDL pathway. So there's another drug that's now available that I hardly ever use. In fact, I don't think I've ever used it. And then there are a number of others that are in clinical development now as well.
Okay. So what about targets? So I know it depends on the person, right? What you're saying is if you had an event or you have other risk factors, if you have a family history, your target may be different. In general, do you have any concerns about going too low? Is it sort of like lower is better as long as you don't have other side effects? What's your sort of take?
Yeah, I mean, this is a controversial area, obviously, especially online. But that what you just described is basically the way I practice. So again, depending on risk, I don't want somebody who is, sort of a young-ish, healthy person with, say, a family history and maybe like just one risk factor. I don't necessarily care if that person's LDL cholesterol is or ApoB is down in the 20s and 30s. I, I don't think there's any harm or risk to it, but I probably wouldn't start 3 different medicines or 2 different medicines to get them there. The flip side is that it's somebody who's had a heart attack, particularly somebody who's had a second heart attack. I am extremely aggressive. And so I would say most of my, what you might call tertiary prevention patients, so these are people who've had 2 events. And I'd say a large number, if not most of my secondary prevention patients, I have on multiple drugs and have aimed to get their ApoB as low as I possibly can. Again, without causing problems. And
so can you talk about some of that? Like that's one thing I think I'd like to know. Of course, side effects like maybe muscle cramps or something, but like in terms of health, do you have any effect on blood sugar or something when you start having some of these drugs? How do you sort of make sure you don't have any
yeah,
unwanted side effects?
well, so there's a well-known effect of statins and actually Zetia as well on glycemia, for lack of a better word. So those drugs, and actually this has been borne out in the genetics as well. So if you go back and look retrospectively, you can see that human genetics would predict that variation in HMG-CoA reductase, which is the molecular target of statins, that is associated with a decrease in risk of disease, so loss of function, decrease in risk of coronary disease and coronary disease events. That's real, but also a slight increase in risk of diabetes and in hemoglobin A1C. That's true. So that's true both from human genetics. It's also true from pharmacology. So we know, again, in large numbers of people that there's a very modest effect, both in terms of increasing the A1C biomarker as well as the increase in the risk of developing type 2 diabetes. Now, importantly, and I tell all my patients this, that change, the most important thing that I said was the first part, which is the reduction in risk of coronary disease events and risk of dying. Sometimes people get very obsessed with the diabetes, but the fact that you're still seeing a reduction in risk despite an increase in the risk of diabetes, to me, tells me that sort of that supersedes everything else. So it's not that I ignore it, and most patients don't want to ignore it. So the good news is there are other ways to lower LDL cholesterol that don't involve. If you saw somebody who, say, you put on a statin, their A1C went from, say, 5.9 to 6.6. You could, there are lots of ways to kind of mitigate against that.
Try different types of drugs
different medicines. Yeah.
Different medicines.
So,
and then you monitor. I guess that's the key thing. If somebody cares or if you care about that, you check it, see what it does. And starting on the lower dose, it sounds like lowest effective dose to get to the level that you want to be
again,
at.
depends on risk. If somebody is sort of really, really high risk, they fall into that sort of super ultra high risk category where they're having lots of events. I don't care what their A1C is. I just want the number to be down as low as possible. So that's sort of different than your sort of standard primary prevention younger patient who's really just trying to optimize their sort of long-term health. There, I would take a very different approach where I'd start low and increase as needed.
Okay. So what about some of these genetic factors? I'm thinking about LP little a, which mine is elevated. I have elevated LP little a. Are there any new drugs out there or ways to lower that? Because I know historically it's been that it's kind of hard to lower that with any types of medications.
But I guess just one slight correction, which is that everything is genetic. I mean, obviously there's a lifestyle component to a lot of things too. I think the difference with LP little a is it's highly genetic. And there's not a huge impact of lifestyle. Now, some people will argue that there is, but for the most part, there's not a huge impact of lifestyle on Lp(a). So Lp(a) is an interesting biomarker. Like I said, it's ApoB containing. It's sort of a cousin of LDL. It's observed through sort of the multiple lines of evidence that we look at, right? So there's epidemiology, which we've had forever, genetics, and there's pharmacology. So we have 2 out of the 3 for Lp(a). We have epidemiology showing the higher your Lp(a), the higher your risk, above a threshold probably. So if you're If your Lp(a) is sort of 10% higher than the upper limit of normal, it's probably not a huge impact. But if it's 100% higher, it probably is. And so there does look to be a threshold above which it really matters, below which it probably doesn't matter that much. It probably does matter for how these drugs that are eventually going to come to market are going to be developed. And so drug companies think a lot about that when they design their trials. So the second one is genetics. Again, same thing. Genetic variation in Lp(a) tends to correlate with risk in a positive and negative way. And, that's part of the reason why people are so enthusiastic and predicting that the drug trials are going to work. So there are now multiple different drugs that are in various stages of clinical development to lower Lp(a). Again, and generally in people with very high risk and very high Lp(a). Got to have high risk and high Lp(a). Generally, high risk means in clinical trial setting that you've had a heart attack. So say take people who have a heart attack and have high Lp(a). That's how they're getting into these trials. There are some primary prevention trials happening, but the vast minority. So, and those drugs all lower Lp(a). Most of those drugs do sit through a mechanism where they involve knocking down messenger RNA to kind of turn it off at the source, basically within the liver cell. And we should have results from those trials, over the next 1 to 4 to 5 years. And, we don't, again, what I tell my patients when they say, when can I get one of these drugs? I'll say, well, you can get one of these drugs when they get approved. And the question, of course, is the trial going to work? Now, let's think about it for a second. What if the trial works? Then great. Then we have another thing that we can really concentrate on. It's obvious and it's easy. You show up in my office, either in a primary or secondary prevention setting. It doesn't matter as long as the trials support that it works in either. Mm-hmm. And your Lp(a) is high, then we put you on one of these drugs that lowers it. You lower your risk. Obviously, they're more important in the higher risk categories like secondary prevention. If the trials don't work, so why is that? And I think, there are two reasons that could be. One is that we just got it wrong, that the genetics didn't predict what we thought they did. There's something else. Maybe this is a HDL story where for a long time we thought HDL was a negative risk factor. The higher your HDL, the lower your risk. Again, epidemiology really supported that. Initially, maybe human genetics did, although then human genetics started to kind of ask the question. And then there were all these pharmacology trials showing that drugs that were specifically designed to raise HDL actually didn't lower the risk. In some cases, it made it worse. So there may be that you have some that, Lp(a) is just, associated with something that's very closely linked. I think it's unlikely, but it's possible. The more likely, to me at least, reason that these trials might not work is that we just have such good tools already that your risk is so low that you're not going to be able to really even make an impact on lower. Yeah.
So if Lp(a) is lowered from the drug, does that guarantee it's going to have a reduction in risk, or is that not? It doesn't.
No, that's what I'm saying. We don't know. We won't know until we actually. You got to turn the cards over on the clinical trial. So that until that happens, or multiple clinical trials, we won't be able to say for sure that we can fulfill sometimes what people will call Koch's postulates, which is really about microbiology, but that this idea that not only is this causal factor associated with disease, but that if you change it, that you can reduce the risk of disease. So I think until we show that if you can lower Lp(a) and reduce the risk of disease, we don't know for sure that it's anything other than associated. So I think there's no disputing the association. The question is, can you intervene on it? And that's something that we will learn in the next, whatever it is.
So stay tuned. Okay.
Yeah.
So what about when we're thinking about prevention, about how early to start? Do you have any guidance on, is there a particular age? I mean, maybe it depends on your risk factor, but do you suggest that adolescents or young adults start paying attention to these biomarkers, or is it sort of wait until you're a little bit older?
I think it really depends on the context and on the situation. I think there are, and when I mean context and situation, I mean both the sort of medical context, but also the individual patient interests and desires. So I'll just give you an example. There may be a patient who comes to see me who says, philosophically, I'm inclined to want to do everything I can. My grandfather, my father, my uncle, they all died of heart attacks. I don't want to die from a heart attack. I don't care what happens to me in the meantime. I just want you to reduce the risk of me having a heart attack as much as you can. That patient is very different than a patient who may come to me and say, look, I've been told that this biomarker is high and it's a problem. Can you help me understand if it is a problem and what I should do about it? I really don't want to have diabetes. My grandmother and my mother all had diabetes. I don't want diabetes. Also, I've heard that some of these medicines can cause me to have Alzheimer's disease. I don't want that. So these are very different patients where, in one case I might be pretty aggressive right out off the bat because the patient's asking for it. In the other case, it's going to take a lot more sort of working together to figure out what's right for that individual. So, and then, obviously the medical context matters as well. I think the easiest way to break that down is just sort of based on the risk. And we have lots of tools now to help predict risk. The truth is you don't need fancy algorithms or AI or ChatGPT to tell you what the risk is necessarily. At least I should hope I don't. It helps. It can be a little bit more quantitative, but in general, just as we started talking about at the very beginning, you sort of understand the things that drive risk, at least the things that we know today to drive risk. And really, there hasn't been a lot of new stuff that's emerged as like, oh, well, we didn't know about this. Inflammation probably is the biggest one. That inflammation was something that we started talking about in the late 1990s as a big driver of risk.
Mm-hmm.
I think there's now a huge amount of excitement about inflammation, about drugs to potentially modulate inflammation as a way to reduce risk. There have been a few trials that have been shown to do that. Obviously, the risk there is that modulating inflammation means you're messing around with the immune system, which means you're turning it down, which means maybe you're exposing yourself to a risk of an infection. So that's where things are with that one. But for the most part, other than that, there haven't been a lot of kind of novel, really truly novel risk factors. Now, I mentioned this term remnant cholesterol, which is really kind of old wine in new bottles. It's really triglycerides or triglyceride-rich lipoproteins that all of these ApoB containing lipoproteins carry some cholesterol. The amount of cholesterol that remains on that triglyceride-rich lipoprotein particle is remnant cholesterol. So it's just about labels and what you call things.
Okay. Well, I know we went into the weeds there, but I think that's important because it's like you said, it's the number one cause of death in the U.S. and in many places. Can we, I think it's fascinating that you're on a low carb diet. You tell us a little bit about that, and also interesting that you are sort of supportive of lowering saturated fat. So oftentimes people think low carb means you eat a bunch of butter.
Right.
A bunch of bacon, a bunch of, whatever, saturated fat. Can you tell us what your sort of take is? Sort of what is your story with the low carb diet? How'd you get interested in that?
Yeah, my story, again, I'll try to be concise, which is not a strength. I had, sort of towards the middle of my career, gotten really interested in lifestyle interventions as a way to help mitigate against risk, and started to work with some companies local here in San Francisco that were developing tools to help people use lifestyle. Through a series of connections, I ended up getting introduced to a company called Virta Health, which was developing a tool to help people use low carb diets to help reduce their risk of diabetes. When I met the people from Virta, which was probably 2017, 2016, I knew about ketogenic or low carb diets. I knew about Atkins. I'd never thought of doing it myself. I thought the whole thing was frankly a little bit weird. And I thought that they themselves might be a little bit weird. And like there was like a cultish quality to the whole thing. And I distinctly remember going to a dinner one night where we were at a Mexican restaurant and there were, a whole spread of things, including bowls of guacamole and fajitas and all this stuff, but no tortillas and no chips. And I was like, this is just like people are eating guacamole with a spoon. Like this is a freak show. The more I dug in, the more I was like, oh, this is interesting. And the data looked pretty good. And they were doing something I thought was novel and interesting. I ended up joining their advisory board. I did not then go on low carb. I actually only went and started doing low carb myself a year or so later because I was thinking about ways to use technology to help to help enable behavior change, really with the aim of improving metabolic health. And so we were in the process, we were developing a tool to basically allow you to measure acetone in the breath as a surrogate for ketones. And I was playing around with a prototype of that. Again, no intention of actually doing low carb for any amount of time, specifically not for 10 years. But I was playing with this device and I got gamified. And I was like, I just want that number to go up. And actually that was a moment where I was like, well, this could be really interesting. Like if I got sucked into this thing, then maybe there's something there. We ended up starting a company around it. And, the company didn't end up, succeeding, at least not in its initial form. I think that was partly because doing low carb or ketogenic diets is actually hard for the average person. I also think, it was right around the time that GLP-1 receptor trials were coming out and people were realizing, gosh, I don't have to like blow into some device and like eat, I can eat kind of almost whatever I want.
A bowl of guacamole without tortilla.
I happen to just like the way I felt. And again, people will make all kinds of claims about things that ketogenic or low carb diets do. I was like, this works for me. And I did lose pretty substantial amount of weight. Who knows if I had changed my diet to any other diet, if I would have lost the same amount of weight. Sometimes just changing your diet is enough, and you limit the number of things you eat, and you're paying attention to what you're eating. And look, I was probably late 40s at the time, and got put on weight after sort of having a couple of kids and the whole thing. And I was just it was a good time for me to kind of play around, and I loved it. I just have never really changed. Now I'm not at all strict, and I will have almost anything. I don't have a lot of things often. So like I don't have bread with my dinner every night. I don't eat sandwiches. I don't really drink beer. Like there are just certain things that I just like don't do often. That said, if I want to go out and have sushi, I'm going to go out and have sushi. I'm going to do that a few times a month and not think about eating rice and not even, be concerned. And I don't measure my ketones or any other, I haven't measured my level of ketosis on a personal level in probably 6 years, maybe 5. But so that's my low carb story. Again, I have always, since the very beginning, and again, as a cardiologist who sort of grew up in sort of the sort of traditional dogmatic sort of lipid centered world of cardiology, I was always uncomfortable with increasing saturated fat as a means to develop to ketosis. So like I thought this idea that you were just going to eat a bunch of bacon and be eating butter seemed like it was going to be hard for me to pull that off as a cardiologist. So I was early days introduced to this concept and this term of Mediterranean keto, which I think really is the Mediterranean diet, which we sort of talked about before, which is really kind of lean proteins, lots of vegetables, fish, chicken, and in the Mediterranean diet, there's also, I think, sort of a grain, whether it's, sort of rice or pasta or, quinoa or even bread. In the low carb version of a Mediterranean diet, that just goes away. So it's really a Mediterranean diet without the grain, and that's the diet that I've been eating.
So a lot of monounsaturated fats and I
mono
guess
and some polys.
Nuts and seeds.
And polys, nuts, seeds, salmon, avocado. I mean,
good mix of all that.
And so healthy fats, which I think are not only not bad for you. That was probably a revelation for me that not all fat is bad, and particularly that some fats are not only not just not bad, they're good. So I try to augment and increase my intake of healthy fats, the kinds of fats you get in salmon and avocado and nuts and seeds and things like that. I don't not eat saturated fat. I will. Sometimes people will say I'm a vegan or low saturated fat. I'll have lamb or pork or whatever it is. I just don't do it very often. So, and I don't go out of my way to do it. And I don't feel like getting into ketosis, which I don't even know if I'm in it or have been in it for years, but I don't feel like there's like a magic to getting into ketosis through eating saturated fats versus unsaturated fats. I don't think there's I think this whole seed oil thing is frankly just noise and distracting. I think, there's as much evidence to support that what people would call seed oils or polyunsaturated fats are as healthy as they are unhealthy. And I really think in some ways thinking about macros or thinking about subcategories of macros is not helpful to the average person. I think it's really about thinking about food. So when I talk to people, I talk about what foods I try to eat and what foods I tend to minimize. And I don't ever use the word avoid. I just say minimize. So like I say, look, I tend to minimize my intake of bread. I likewise minimize my intake of, very fatty meat. So
okay, so now that's your personal experience is really fascinating because I think there's obviously a lot of interest in certain communities. I think in the individuals who are really into like optimizing, focusing on all the stuff they can control. I think low carb has really picked up and taken off. What about if you just look at the evidence in terms of the benefits and the risk? You said it's maybe has a slight edge on sort of the diabetes literature. You said for some people, the weight loss is pretty clear. How about any other potential risks? What about the lipid story? Even with the low saturated fat, do you sort of have good lipids with that in general? Can people have a good cardiovascular profile there?
Yeah, this is a messy area, which unfortunately has become sort of cluttered with a bunch of personal anecdote and dogma. My belief is that the lipid risk is the only substantial risk. I know that there are a lot of people who have theories and opinions about effects on thyroid or bone or other things. I haven't seen any evidence that adhering to a mostly low carb, even borderline ketogenic diet has any long-term health effects. And in fact, people have been using ketogenic diets for medical therapy for over 100 years because they've been using it in kids with epilepsy, again, since the 1920s. So I think if there were like really, really bad effects beyond the lipids, we'd see it. So I'm not worried about anything else besides the lipids. The lipids, to me, I think in my experience, both personally and in my experience as a practitioner, a lot of the impact on raising bad cholesterol and raising LDL cholesterol, ApoB containing lipoproteins, can be mitigated by swapping out saturated fat for unsaturated fat. So specifically replace the fatty piece of lamb with a fatty piece of salmon. I mean, that's just like the simplest thing. And so in the vast majority of people that I've worked with, including myself, that mitigates most, if not all, of the impact on lipids.
So you get the benefits. You get the benefits to all the other areas, and you can kind of not have any sort of increased risk, right?
I know that there are people out there who believe, and they state that that's not the case. I haven't seen it in my own experience, either personally or professionally, that there's somebody out there who's like, lean and goes on a low carb diet and their lipids skyrocket even if they're eating almost no saturated fat. I've just not seen that. So I'm sure it exists. If it does, like everything else, you're left with a choice. And your choice is, okay, do I love this diet so much, or do I need this diet so much that I have to stay on it? If the answer is yes, and if the answer is that diet causes what I think to be the most important potential risk of dying from the most common disease in the world, we're not talking about edge cases of weird things. We're talking about the most common cause of death in the world. If this diet increases your risk of dying from that disease, then you got to do something about it. And your choices at that point are you either change your diet or you take a medicine. And I don't have a strong opinion about which one works. Now, if somebody comes in having a heart attack, they got to be on a medicine anyway. That's standard of care. That is guideline directed. There's no question about that. Every guideline in the world would say secondary prevention should be treated aggressively with lipid lowering medications, independent of whatever the starting lipids are. It doesn't matter if your starting lipids are 30, you still should be on a medicine. And that sometimes is hard to understand. But in people who have not had a heart attack, then it really is a choice. And I think everyone should be enabled to make the choice. Now, if somebody says to me, I understand everything you're telling me, and I don't want to take a statin, and I want to stay on my diet, I'm not going to say fire them. I mean, I've never said, oh, I'm not going to take care of you, and you're a moron, you're an idiot. My job is to help present information and to help people make decisions. That's my job, and I'm not making decisions, and I don't ever want to be in a position of making a decision. Sometimes I'll have somebody tell me, what would you do? Or I'll have somebody say, would you please make this decision for me? That's a different story. But an average person, I'm not there to be making their decisions. I'm there to help give them information. Obviously, the information I give them has bias. We all have bias. I try as best I can to give them some understanding of what my biases are, and so that they can make the most informed decision.
Wow. Okay. Well, I would love for you to be my preventative cardiologist. It sounds like you treat people, I think, with respect. You give them the autonomy to make the choice, but you give them the information so that they can make an informed choice. And I think that's pretty important. You've also done some work in your research on time-restricted eating. Can you tell us a little bit about the evidence on time-restricted eating? And you published a study, I think maybe this was 2 years ago at this point, or a few years ago, where...
Oh, no, it's longer than that. Yeah, I think it was 2020. It was probably 5 years ago.
5 years ago. So tell us about that study, your findings. Did you have any sort of change to your view? What got you interested in time-restricted eating in the start?
Yeah. So again, I told you that I was kind of getting interested in using lifestyle to help mitigate risk, and specifically metabolic risk. And it was in the early part, say 2011, 2012, there was a lot of really interesting work largely coming out of Southern California, showing that in rodent models of metabolic disease, that you could reduce weight and reduce metabolic risk by putting mice on what they would call time-restricted feeding versus eating, because the mice get fed. And they were compelling results. And it was kind of interesting, right? Simple thing, right? If you take a mouse and you feed the mouse the same exact food and the same quantity of food, so it's the same diet, no difference in macros, and it's just exactly the same chow. You feed it to them, instead of giving it to them 24 hours a day, which is how mice are fed, there's a feeder, it's there. They tend to eat mostly at night, but they can have access to it all day long. If you narrow the window to give them the same amount of food down, I can't remember the exact numbers it was, but it was not that much. It was like 8 hours or 9 hours or something. If you narrow that number down, those mice lose a bunch of weight and get metabolically healthy. And so that sort of set off a huge amount of interest. I paid attention to it. I was like, wow, this is amazing. This could be like a really game-changing intervention. It's not complicated. You don't need a device. You don't need a calculator. You just need to know when you're allowed to eat.
You don't even need to worry about what you eat.
You don't need to worry about what you eat. And that was the thing that was amazing. You could I think the first few papers were all on cell metabolism. There was a cartoon of like a mouse eating a cheeseburger. And like basically the idea was you can eat whatever you want, just as long as you eat it during this narrow window, you can, you'll have all this metabolic benefit. So I got enamored by it. I got caught up in it. I started doing it myself. I started telling my patients about it. I was like, this is amazing. And then, I had a moment where I thought, well, before I start getting really too evangelical about this, we should probably see if there's like any human data. Like, do we know anything other than what happens in mice? So I looked and I didn't see any human clinical trials. And so I got together with some colleagues when I was still at UCSF and designed a trial. And it was a simple trial where we just took a group of people. We decided we'd randomize them to one of two interventions. Now, we were very careful at that time that we didn't want to give it away what we thought was the actual intervention and what was the control, because sometimes people can be biased. And we didn't want people to think like if they got randomized to what we were considering the control, that they weren't going to have any benefit. So we just named two different diets. One I think we called like balanced meals, and the other one we called time restricted eating. And the only intervention was in the people who were randomly assigned to get time restricted eating. They had an app that told them they can eat during these brief windows. So for breakfast, say like, I don't remember the numbers, 5:30 to 7:30, somewhere, whatever. Lunch was like 11:30 to 2:30. Dinner was 5:30 to 7:30 or 8 o'clock. So basically between the hours, and then they couldn't eat. But then, between the hours of 8 p.m. and 12 p.m., sorry, they don't eat breakfast. Sorry, I just messed that up. That's what I just described to you as the balanced meal timing. The time restricted timing, they could only start eating at 12 o'clock noon. So they would be fasting from 8 p.m. to 12. And then they could eat in between those hours.
16 hours of
16 and fasting. 8. Yeah, 16 hours of fasting, which honestly people will say that's so long. It's not that much longer than a normal person fast. I mean, we all sleep roughly 8 hours a night. So you're fasting 8 hours. It's a little bit longer. You're sort of not doing snacking at night, and then you're also not eating breakfast. So we did this. I think it was roughly about 150 people. The primary outcome was weight, and I won't get into all the other secondary outcomes. We looked at everything, and at the end of the day, there was no difference. And I tell this story, and I've told it 100 times. I'll tell it to you now because I think it's really instructive. But I had a graduate student named Dylan Lowe who was working on this with me. Basically, did the whole study, and Dylan and I were talking to the statistician who was working on this project with us. And every time we got the data back, Dylan would send it to me, and I was like, "Can you ask the statistician to rerun it this way?" And after about the fourth or fifth time, now mind you, I was a believer, a true believer. I had done it myself. I was telling people to do it. And so after the fourth or fifth time, I got an email back from the statistician, and he's like, "Hey guys, I can continue to do these analyses as many more times as you want me to. I'm not getting tired of it, but it's not going to show anything. There's no difference here. There's absolutely no difference." And so it was kind of an interesting thing, right? Because I had this belief that this was going to work. It was going to solve metabolic disease. It was going to solve weight loss. It was going to be easy. It was going to recapitulate exactly what we saw in the mice. And it didn't work. Now, it was a real world study. There are all kinds of potential limitations and caveats, but in our hands, it did not work. And I think when I then went back, at that time, there were many more trials. And since then, there have been many, 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 many more trials. And when I go back and look at the data, again, from a 35,000 foot level, whatever impact you're seeing here is really modest and probably not clinically relevant. We're not talking about the kinds of things you see with the GLP-1 receptor agonist or with bariatric surgery. We're talking about a few percentage points here or there. Maybe in some people it can work beautifully, in others it doesn't work at all. And some people gain weight. I think maybe, and there's a lot of work going on still, maybe there's a difference about when you fast. So maybe the amount of hours you fast is important, but it's when you take that fast. So in other words, Instead of skipping breakfast, so fasting from 12 p.m. to 8 p.m. to 12 p.m., that if you fasted in the evening, so if you ate all of your meals early in the day, that might be better. So so-called early time restricted eating, where you're having
like an 8 to 4.
Or no,
Let's
even
say
like 6 to 2,
6 to
which
2,
I think a
yeah.
lot of people do. Now, that looks better. Maybe there's like a slight advantage. The problem with that is that one just takes at least the way we in the Western world live and throws it upside down. So I think
Yeah.
breakfast is really the least social meal that we have. None of us eat breakfast. I mean, I should
It's
say
the
no, but like,
easiest one to skip.
it's just so easy to skip. Whereas dinner
Yeah.
is a very social meal. You're sitting down with your family. The idea that you'd sit down at the dinner table and not, after 2 o'clock, all you would have was water. Like, I think that doesn't solve the thing that I thought was the most interesting about this intervention, which was it's easy. And now
Right.
all of a sudden you've taken something that should be easy and you've made it really hard. So my feelings on time restricted eating have sort of shifted from I'm a proselytizer and I believe in it to not that I think it's dangerous or bad. I certainly think it can work for certain people. I just think as an intervention that's going to have an impact on a population, this is not going to be it. So
It's not the big thing.
I don't recommend that people necessarily stop. I don't recommend that they do it though. And again, if it makes you happy and you enjoy it, you like the way you feel, go for it. I'm not going to tell you not to do it.
What about effects on muscle mass? Do you see any loss in muscle mass if you fast for too long?
Yeah. So, like I said earlier, we looked at a lot of different things besides the primary endpoint, which is weight. One of those things was body composition. And again, I think this got a lot of attention in the press because that's what the press does. They focus on things that are controversial. It got a lot of attention in the people who are big advocates of time restricted eating. What we saw was that sort of on a normal weight loss intervention, whatever it is, whether it's bariatric surgery, GLP-1 receptor agonists, dieting, whatever it is, on average, if you lose a kilogram of weight, 2/3 of that is going to be fat mass and 1/3 of that is going to be what we call lean mass or fat-free mass, being completely specific about it. That ratio is similar no matter how you do it. I mean, maybe a few percentage either direction. What we saw in this very small trial that was 12 weeks long was a flip where it looked like people who did lose, because both groups lost weight, they lost about 3% of their body weight. They lost a few kilograms. They were about 100 degree inputs. They lost 3 kilograms.
Mm-hmm.
Both groups did, whether you were on the time restricted eating or the whatever we call it, continuous meal timing. Didn't matter. But in the people who were on time restricted eating, it looked like their ratio of lean mass to fat mass flipped. They were losing more lean mass relative. Since still they were losing on it for every kilogram, they lost the same amount of weight, but they lost a little bit. They lost basically twice the amount of lean mass. Now, that was early. It was very preliminary. It was a secondary endpoint. If I'd stayed in academics, I probably would have continued to study it. I think there is some biological plausibility to it in that muscle protein synthesis, which is how we sort of build our muscles, occurs mostly in the morning. And so you'd think, well, that's when you want to have the most fuel around. You want to have the most fuel substrate when you're actually building muscle. And so if you're fasting during that time, maybe that does make an impact on your ability to make new muscle. So, but again, that's all speculative and I wouldn't put a lot of weight in it, except, again, it comes down to context. If I have an older person who's already sarcopenic, who's really focused on trying to maintain whatever lean mass they have, then I might steer them away from any fasting intervention, whether it's time restricted eating or any other of the fasting interventions, just because of the potential impact. The truth is, any weight loss intervention, this has come up with GLP-1 receptor agonists, because people are freaking out that you're losing muscle mass. Any weight loss intervention is going to cause muscle mass loss. Every single one. There's no way to. And if you think about it from a teleologic standpoint, it makes a lot of sense, right? If you're heavier, if you weigh 200 pounds,
You
you're
need
going
more
to need
muscle.
a lot more muscle to carry your body around than if you weigh 100 pounds.
You're
So
just constantly getting extra exercise to a
and
higher degree.
it is
Yeah.
definitely true that people, as they gain weight, gain both lean and fat mass. And as you lose weight, you lose both. There's no doubt about it. It makes tons of sense. I mean, a rhinoceros is going to have a whole different amount of, lean mass or muscle mass than a mouse. It's just the way it is. So.
Yeah. So, okay. So in general, I'm hearing not a huge impact overall. If it works for you, great. You don't evangelize about it. Do you have any particular guidance for the average person about, are there benefits to restricting sometimes? So thinking like when to have your last meal of the day and the first meal of the day. Do you feel like it's really just not that important? Or do you think like having a space of at least 12 hours is still beneficial compared to maybe
I mean,
8 hours or something?
look, I've got like ideas that's all made up and an opinion. And I think, when I am feeling good about myself in terms of like, I'm at the right weight and I feel like I'm not overweight, I'm generally not snacking at night, which was my like kryptonite, right? When I
So
got in
stopping to eat
trouble,
after dinner.
I mean, when I got in trouble, it was because I'd sit down in front of the TV and, you know, eat a bunch of crap. And
What age were your kids at that time?
oh gosh,
I'm just kidding.
I mean, this
Did
would
that
have
have any
been,
factor in it?
yeah, of course. I mean, they were young and
You
like
needed that, or
tired.
you
Yeah.
needed that. Yeah, you
Yeah. And it
needed
was
that
just a
sort
way
of
of like
comfort.
winding down. So
Yeah,
that was
exactly.
like an area where I feel like I probably, gained a lot or lost a lot, I guess. Uh, look, there's this whole idea about you don't want to go to bed on a full stomach. I mean, I don't know. I think honestly, the more important thing is to focus on the big picture, which is can you maintain a healthy body weight, a healthy body composition, and however you tend to get there to me is not as important as where you get. So I try not to
Yeah.
get people too focused on too many things that they lose sight of what really matters. Like I don't want somebody to think like, oh, if I don't eat anything after 8 o'clock, I don't care if I weigh if my BMI is 40. Actually,
Mhm.
what really matters is your BMI is 40. Don't worry about when you eat. I mean, maybe
Yeah.
worry about it if it helps you get to a healthy BMI, but don't worry
Yeah.
about it. Yeah.
Yeah. Okay. All right. That makes sense. So this just wrapping up everything, I think, you're still doing a lot of research. I think we haven't talked about much of the new stuff, but do you have anything that's sort of exciting, either from your ongoing research or something that you've recently published that you want to share?
I mean, all of the publications that I've had recently are from this company that I helped to start 5 years ago that I'm, working full time uh, as chief scientific officer. So that's what I work on. It's a biotech company, that we got started, and the cardio-endocrine thing, and it's been a blast. So all of my publications have been related to that, and I mean, I'm having fun. We're still relatively early. I mean, we have two clinical stage drugs, which is nice, but they're still relatively early in clinical development. So there's nothing on the market. I can't, I'm not recommending anyone take anything because they can't, unless
Okay.
they get
So
into a
you're
clinical
still
trial.
doing all the trials and seeing how,
We're,
do they seem promising? Or
yeah, I mean,
what exactly doing?
yeah. So the first one is a lipid drug that lowers triglyceride-rich lipoproteins or triglycerides and remnant cholesterol, and we think that that's going to be important in reducing cardiovascular risk in people who have high triglycerides or high remnant cholesterol. That's something we're really excited about. It's not a replacement for statins. Everyone who has had a heart attack, which is the population of people we'll be focused on, those people all need to be on statins or some equivalent. They need to have their LDL cholesterol treated appropriately. We're not talking about replacing that or changing the paradigm. What we're saying is in people who have this risk and they have a high elevation in one of these biomarkers, that this would be the kind of people that we're going to study and see if lowering that will impact their risk. So yes, we're excited. We think there are probably 5 to 10 million people in the United States alone who would fall into that category. And so it potentially could be an important way to identify and mitigate risk in a large number of people. And it's an area that I think has been underappreciated. I mean, there's been a lot of work on the scientific side and on the drug development side on the LDL pathway. I think it's important. It's clearly been the most important thing, but we've got that kind of solved at this point. And so
Mhm.
when I decided I was going to make this leap to industry, I decided I didn't want to do something that everyone else was already doing. And so sort of looked for some opportunity that we thought where we'd be able to make an impact, but to do so in a way that was relatively novel and creative. Our second program is completely unrelated. It's a rare disease, rare neuroendocrine disease called acromegaly, where patients have a tumor that secretes too much growth hormone, and we're just developing a drug to help basically block the actions of that hormone. And that one's incredibly exciting, obviously totally different. There may be worlds in which these two things merge together and that this drug, this first drug that we're developing could be useful in more, sort of broader chronic disease areas as opposed to, these rare disease areas. And likewise, there are some potential, you know, rare disease and, indications that we could think about for the first program. So we're just kind of trucking along, doing what people do in this business, and it's been a blast.
Awesome. Well, I've really admired your work. You're one of these people who I feel is very balanced. You don't get too caught up, even if you're really passionate about something. it really seems like you try to look at things pretty objectively as much as you can. So I've always appreciated that about you, and really appreciate you taking the time, Dr. Ethan Weiss. I really enjoyed our conversation.
Thank you. Likewise. It's been super fun.